My name's Paul Karanicholas. I'm one of the two surgeons in the room, and Sadish has
doesn't look good for me.
A tough job. Yeah, his only advantage is that the moderator's on his side. So the question for today is: should perioperative medicine move towards a unifying single interdisciplinary perioperative medicine service made up of interested anesthesiologists, medicine specialists, and surgeons to co-manage patients after surgery and into the home setting? So it's Mother's Day weekend, and I think because of that, it's reasonable to think about what our mothers would tell us. And my mama always said, if you break it, you better fix it. And I try to remember that in my life and in my practice. And so when I operate on patients, I like to take care of them and help get them better. This debate today is really questioning Mama's advice, and there's nothing that I hate more than people who question my mother's advice. So PJ is really in trouble here.
Sounds delusional up here slightly.
So PJ, on the one hand here, is going to be arguing in favor of this, and PJ really needs no introduction. He falls into that category of people like Madonna and Prince that are, known around the world by first name alone. And he's running the conference, so we'll do our best to humor his point and try not to interrupt too much. Sadish Srinathan over here is a highly skilled doctor who treats patients with his hands, his heart, and his head. He's a thoracic surgeon and a researcher in Winnipeg, and he'll be arguing that Mama knows best. So we're going to have opening statements first. I will ask each debater to limit themselves to 2 minutes, please. I will carefully monitor that. And PJ will go first.
Mr. Moderator.
So time's up.
Okay. Mr. Moderator, ladies and gentlemen, let me paint a picture for you of perioperative care. And this comes from traveling around the world, talking to a lot of surgeons, a lot of anesthetists, and a lot of people in medicine. And I put forward to you that perioperative care falls into two categories, two models. Model number one, patient goes to surgery, goes back to the surgical ward, and essentially the surgeon's the only one who takes care of them. This model is commonly referred to as Darwinism and survival of the fittest. That's model number one. Model number two is where there's various subspecialty groups, internal medicine, perioperative vascular service, thrombosis service, infectious disease service, pain service, who all see the patient preoperatively, are then involved with the patient postoperatively, and then the patient leaves the hospital and they follow up with the patient, typically the surgeon once, at about 30 days. This is referred to as the maximally irritating model to the patients because they have to have so many preoperative clinic visits and they get very irritated by this. I'm arguing for moving away from these two models and moving to a single model, whether it be perioperative care, where along with the surgeon, a single individual would co-manage the patient throughout the hospitalization. And this would ideally be a multidisciplinary model, which would have people from internal medicine, surgery, and anesthesia, similar to the ICU model, where we can advance care for these patients. Now, I want to acknowledge right up front, I am guilty of exacerbating Model 2. I created the perioperative vascular service in Hamilton. Although I think it's helped patients, it's not the right model. It's not the future. Large perioperative trials and observational studies show us there's a lot of competing physiology in the perioperative setting. We shouldn't have people that are focused only on their issue and not taking the broader patient into account. We need a group that's going to focus on this. And moderator and Mr. Moderator, Dr. Surgeon Moderator, ladies and gentlemen, please vote for a better future.
Okay. All right, Sadish, help us out here. Come on.
Well, ladies and gentlemen, I would like you to consider the following scenario. It's 9 a.m. The surgeons are already in the operating room because they've already rounded on their patients in the OR. Now the perioperative service is arriving. Well, hello, Mrs. Smith. How are you today? I'm Dr. Devereaux, your perioperative care specialist, and we are the Perioperative Care Committee, and we're going to look after you today. This is Dr. Anderson from anesthesia, Dr. Mortimer, our endocrinologist, and Dr. Smith, our thoracic surgeon, who is part of our team today. We understand your gallbladder operation went very well. Oh, you had a hip replacement. Okay, well, funny, we were told that you actually had a gallbladder operation, but it doesn't matter since all operations are the same anyway. Now, we see from your automated monitors that your blood pressure was very low this morning. Well, that is rather concerning. So is there a nurse here who was there overnight? Oh, okay, well, he's on break. Okay, anyway, doesn't matter. Now, Dr. Anderson, what do you think we should do? Well, you know, I think the anesthesia is probably worn off now, so I don't think that's the reason he's got a low blood pressure. And Dr. Smith, your suggestion is to put a chest tube into this patient, but they just had a hip replacement. So I don't think this is quite the right thing to do. So what shall we do now? Perhaps a show of hands to make a decision on this patient. That, ladies and gentlemen, Dr. Devereaux proposed a model of care which is like the group of blind men examining an elephant. They all have a pretty good picture of one certain aspect, but not the overall view. Folks, I put it to you that perioperative care begins at the surgeon's clinic when the decision to operate is made. The patient and the family places their trust in the surgeon and expect her to continue to be responsible for them until they are better, not just until discharged. As PJ himself noted on Thursday when we were chatting, patients do care if they are seen and cared for by their surgeons. Patients and their families recognize that knowing the whole situation is important and details matter. Patients have poor outcomes from many different pathways, and the paths which the surgical team, ultimately responsible for the patient, is aware of. I put it to you, the audience, that my opponent has that more than reacting to problems, it's best to anticipate problems. That requires knowledge of details which are only available through the prolonged and continuous exposure to the patient and to be actually responsible to them and for them. This is why the surgical team should remain primarily responsible for the patient's perioperative care.
Okay, tough words. Oh gosh, I'm glad I don't have to answer all of that. So, PJ.
Okay, my opponent believes that surgeons are available. Really? I propose 2 tests. The first test is 9 a.m., page the surgeon. Make sure you have 2 cups of coffee. You'll be waiting a while before you get the return. Secondly, show the surgeon a schematic of the hospital. Ask them to point out their post-operative surgical floor, the ICU, and CCU. I predict the evidence will say there's a misunderstanding of what's going on in post-operative care with surgeons. My colleague argues that we want people that are specific, have great knowledge about the specific type of surgery, and I would agree with that, of course. But to suggest that we can't get that with people who focus on perioperative medicine is basically to slap all the anesthetists in the room in the face. Anesthetists commonly do all kinds of non-cardiac surgery. Are we suggesting that they're putting people at risk? If you think that, then you should vote for him. But if you're against that, you should vote for me. Also, I want to remind you of the history that has happened with surgeons. When surgery first started, there were no anesthetists. What did surgeons do? They gave the patient a shot of whiskey or punched them in the head, had their buddies hold the patient down, and perform surgery. Do we really want this approach to our loved ones? We need to have, it was only when anesthetists showed up that we actually made them safe. We need a group that's going to be available to take care of these patients and make things safe.
Oh. Please hold your applause until after Satish speaks.
Yeah. Well, it's, you know, I had a number of comments, but I'll rebut Dr. Devereaux, PJ's comments. First of all, are patients unavailable? That is a straw man argument. I have no idea what he's talking about because we actually have people on the surgical team available on the wards.
This is a mythical land that we're talking about now.
Yes, called Winnipeg.
A very cold mythical land.
With a good hockey team. Now, the other component is the issue of, so as you know, PJ is basically sucking up to the anesthetists, right? And so
I'm pointing out their brilliance.
Well, there you go. Okay. But I think the important distinction, though, is, and my anesthesiology colleagues are dear friends, and in fact, I couldn't do what I do without them. Now, the component, though, is that we do, in fact, talk to each other about our patients continually during the operation. So that is true that they may look after lots of patients, but when they're in our OR, we talk about that patient and their individual problems continually. That is not what happens when the patients go to the ward. Okay? At that point, it is absolutely crucial that somebody knows all the details of the patient is available. Now, we already know that fragmented care leads to poor outcomes, and I'm not convinced that a separate perioperative service which would basically firmly establish this fragmentation, and in the vain hope that this will fix a problem in the perioperative care is the solution. The reality is perioperative care begins from the moment the patient sees a surgeon, and decisions to operate are informed by expectation of the perioperative outcomes, and this proposal divorces perioperative care from the overall surgical care of the patient. Co-management is one step away from no management.
Okay, strong words again. Thank you. So we're on to the firing line phase now. I have 2 questions for our debaters. The first, if surgeons are indeed replaced as the most responsible physician in the postoperative period, as has been suggested, what side job will they take on to replace the $55.60 in missing income?
Okay, we're now getting to the heart of the matter. Okay. I mean, it would be outrageous that a surgeon should make less than $500,000 a year, but maybe we can get a support program for them on this. What I would advocate is that we have the surgeons actually go to the front doors and act as greeters. We'll pay them a bit of money. This will help them transition later in life to their Walmart jobs as they slow down doing surgery.
Satish, what are we going to do?
Become baristas so we can serve our perioperative care team.
Okay. All right. Second question for each of you. So PJ in particular, we've heard about surgeons' limited availability due to being in the operating room and challenges getting a hold of them. In your model, what happens if the patient gets sick before 11 a.m. and the internists are still in bed or having tea and biscuits at home?
Well, I guess what you're suggesting is maybe we will have to have shift work. It is true surgeons show up earlier, but usually the surgeon is going to the golf course at 11, so we can just shift over at that time when we arrive.
Satish, any comments?
Well, I was actually going to suggest that the greeter who sees the patients in the hospital serves the purpose, but as PJ already said now, they're actually surgeons. That'll be fine.
Okay, I'll give each of you now 1 minute to finally sell your argument before we let the audience decide who the real winner is.
Ladies and gentlemen, surgeon moderator, you heard earlier Jessica Spence show you data showing that of all the patients who die in the first 30 days after surgery, 0.6% of the deaths occur in the OR. 99.4% occur after the OR. One could easily make the argument that surgery should be the highest risk period. You're doing surgery on the patient, they're under anesthesia, yet the remarkable thing is it's the safest period. 99.4% of deaths will occur after the OR. 100 years ago, we used to do surgery mainly on young patients who had very little comorbidity. Today we do surgery on really old patients who have lots of comorbidity, and despite that, intraoperative death has plummeted. So what has happened? I will put forward to you what has happened is anesthetist has showed up. Having a physician standing over a patient, paying attention to their physiological responses and responding to these problems helps patients. We should be doing the same thing in the postoperative setting. The easy litmus test to ask yourself is it really true you'd rather, if your loved one was having surgery, that they simply went back to a surgical floor and their surgeon would take care of them, or that they would have a specialist in perioperative care that could be a surgeon, could be an anesthetist, could be someone from medicine who is dedicated, available, and focused on their outcome and helping them transition home. Ladies and gentlemen, it is time to vote to bring perioperative care into the 21st century.
Okay, a very campaignish type speech from Mr. Trump.
Well, ladies and gentlemen, and everyone in between, that includes PJ, perioperative care is not just about how you treat a blood pressure or another change in vital signs. It means anticipating problems and understand the clinical path and what the options are for individual patients. It demands that one knows each patient well, the disease process that necessitated the surgery, how they got there, what decisions were made, and what happened during the operation. And I could point this out. Dr. Devereaux suggests that the surgeon looks after the patient, and that is a false dichotomy. It is a surgical team, which is under the care and direction of the surgeon, but it is a team. And
there seems to be a bit of a control issue going on up here with these surgeons. It is.
Yes, it's a bit like the control issue of a pilot piloting a plane. It's not usually a team that's flying the plane. So they still work together. It is absolutely essential that they do, but there are times when, and sometimes an individual takes responsibility. Now, the surgical team is the perioperative team, and we have been caring for the patient in the clinic before the operation, and will continue to do so after they go home for a prolonged period of time. Now, the problem is, in a unifying single interdisciplinary roving perioperative medicine service will serve to unify all surgical specialties into a homogeneous group, ignoring the specific details of each operation. So you just described the importance of specialization. Well, this is going away from that. These differences and details are crucial, and the patients have a right to expect from the surgical team full dedication. So in the famous words of Nancy Reagan, just say no to PJ.
Okay. Thank you. So thank you both for staying on time. A rigorous debate. It's now time for voting. We'll have wild and crazy applause, please. We'll go first with those who are in favor, and those who are opposed will come afterwards to the statement here. So all of those who believe that perioperative medicine should move towards a unifying single interdisciplinary perioperative medicine service, let's hear some applause. Okay. Maybe a little hard to beat that. All those opposed, let's hear some applause. Well, I think it's quite clear who won that one.
There you go.
I want to thank both of you. I think it's a draw. I think we can all agree on that. And I want to thank the audience for
another
your
surgical
participation.
close outcome.
Okay.